in the chat. Otherwise, we'll proceed. Thank you, Lucy. Okay. So in terms of content, there's an awful lot to cover, so we're going to get underway, colleagues. I am really pleased to welcome my colleagues Charlie Cooper and Sarah Fellows, who will be talking to us specifically about the very detailed analysis undertaken around eating disorders in the South East. The recommendations that have come out from that for our system. The thing to say here is that we know the level of children needing our support in this area is the highest we have ever seen since records began. We know that today is not about quick and easy answers, it is a space for us to think together. So Sarah and Charlie will walk us through the key points for us to note and key next steps, both in a regional context and also taking some lessons learned from a national context. So without further ado, I'd really like to welcome Charlie, who will start us off with an overview of what we've learned so far and the key things for us to consider. Charlie.
Hi. Hello, I'm Charlie Cooper, Quality Improvement Lead for all age eating disorders in the South East Region Mental Health Team. And as Andrea has just mentioned, I'm here to present the findings of a recent review into the South East Community Eating Disorder Services and our next steps in supporting clinical colleagues and commissioners. Before I take you through our approach and findings, I thought it would be helpful to put this work into context, just reflecting on what we know about the surge throughout the pandemic and the impact that that's had on eating disorders pathways. We've just moved to slide 4, please, Lucy. Thank you. So the impact of the pandemic can't be overstated when we consider children and young people's mental health services. In some areas, we've seen approximately a 70% increase in referrals, and in particular, community eating disorder services are experiencing significant pressure and holding on to as much of that pressure and risk as is possible and clinically appropriate to try to prevent escalation into inpatient services. Next slide, please, Lucy. Despite this, pressures on specialist inpatient units is also immense, with extended waits for beds and children and young people requiring acute paediatric admission. And we've seen increased prevalence of nasogastric tube feeding, and in some cases, this has included under restraint. Increased complexity and acuity is being seen across all parts of the pathway, from primary care all the way through to inpatient settings, and also in step down back into the community. And many services are reporting that they're seeing an increased prevalence of co-occurring autism spectrum disorder and eating disorder, for example. It goes without saying that the specialist workforce required to support eating disorders pathways is very challenged in terms of meeting the existing demand and also thinking ahead into the future. So it's vital to consider then that NHS benchmarking predicts a further 20 to 60% surge in the next year based on previous trends. And within the South East, we're expected to be at the top end of that surge. The next few slides take us through some of the referral data and trends for both wider mental health services, but also drilling down into community ED. And for the purpose of the presentation, I'll focus on the eating disorder slide. So if you could just take us to slide 10, please, Lucy, that'd be great. Oh, sorry, the next slide, eating. Next slide. Next slide. Next slide. There we go. Thank you. Back up, sorry. Thank you. So new referrals and number of treatments across the South East Eating Disorders teams have significantly increased over the last year. Number of treatments overall for the South East have increased by around 35%, and you can see here that there has been a steep incline in urgent referrals in the last quarter alone. Next slide, please, Lucy. In order to manage clinical risk, services have had to prioritise treatment for urgent cases. And what we can see here is the impact that that's then having on waiting lists for routine cases. As of Q4, there are around 187 routine cases on the waiting list. And the key risk here is that children and young people are waiting for treatment. As they're waiting for treatment, their condition could escalate. And so there's been a real need to ensure that there are clear shared care protocols between services to support physical health monitoring in the community, and also to provide interim support to children and young people and their families. Next slide, please. So it goes without saying that these have been incredibly challenging times, and to support restoration and recovery of services, we carried out a review of all community eating disorders provision across the South East to understand how they've been coping throughout the pandemic and if their models and resource enable them to follow the access and waiting time guidance, meet the national standard and improve patient outcomes. We carried out some demand and capacity modelling using the CREST modelling tool to capture current trends, but also to understand how those trends could translate into future demand and pressures. We worked with commissioners and providers to gather examples of good practice in prevention and early intervention to support improvements at the very front end of the eating disorder pathway. We compiled the findings into a report with a set of strategic recommendations. Next slide, please. So this slide summarises some of the important findings from the CREST demand and capacity modelling. And what this shows is that clearly demand has increased throughout the pandemic, and each lockdown has suppressed access to services, which has then caused peaks in demand much greater than what services could absorb once each lockdown had lifted. Next slide, please. Here we can see that even prior to the pandemic, there was a growing shift towards more urgent presentations, and that urgency ratio has significantly increased throughout the pandemic. And CREST modelling indicates that urgent referrals will make up approximately 35% of all referrals by January next year. This is just so important when we consider the level of workforce required to meet this level of demand, but also when we think about the steps needed to prevent escalation of routine cases. Next slide, please. Wider findings of the pathway review highlight that there are real opportunities to reduce variation in community team service models, where across the South East the offer can vary greatly depending on the location of the team. There are opportunities to enhance access to services by making self-referral processes much more straightforward for children, young people and their families. The need for formally commissioned medical monitoring provision throughout treatment and to prevent escalation whilst waiting for treatment is paramount, and particularly in the context of the pandemic, where patients have experienced longer waits. There are opportunities within the South East to develop shared care protocols to manage this risk more effectively and to prevent escalation. There are significant workforce challenges around recruitment and retention of staff in the South East, and this very much reflects the national picture. We understand that within the South East there is a need for access to training to support staff to deliver nice concordant therapies and to support increasingly complex cases. And we know that there's more work to do to understand how the yearly uplifts in funding have been reaching teams to support them to meet demand and deliver transformation. There are also lots of positive examples that we picked up along the way of good practice around the South East in terms of working really closely with paediatric colleagues, working with early help teams to support children and young people at the earlier stages of their presentation, and thinking creatively about workforce challenges, and they've all been shared throughout the report. Next slide, please. In terms of next steps, we've provided a set of strategic recommendations for systems to consider as part of their all-age eating disorders recovery planning, and these are summarised on this slide. They consider workforce, improving data quality, adjustments to pathways, and building upon opportunities to enhance prevention and early intervention. Next slide, please. Within the South East, we've developed a region-wide implementation plan, and this just provides a bit of a brief update around our work plan here. Our focus has been very much around supporting systems with their recovery planning and bringing back together the sub-regional recovery and best practice forums as networks of peer support, shared learning, and a focus on implementing the strategic recommendations. We're taking immediate steps to support the training needs of staff that were identified in the report, working alongside Health Education England, who will be commissioning training in family therapies for anorexia nervosa, and also considering training around supporting adjustments to pathways to support co-occurring ASD and eating disorders. With funding from the national team, we'll shortly be rolling out the Healthy London Partnership's Pediatric Critical Care in Practice portal. That's going to go to all hospitals for unlimited access to all hospital staff to help raise awareness around eating disorders and self-harm. A recruitment webinar is scheduled for the end of June to help systems think creatively about how new roles can be used to support the pinch points of the eating disorders pathway, but also how to work with voluntary sector organisations to develop their early help offer. And then we also anticipate that the CREST modelling from the report will be really supportive in systems with their 3-year workforce planning. Much of our work programme involves working alongside colleagues in the Learning Disability and Autism team, provider collaboratives and primary care networks, especially when we're thinking about the development of shared care protocols across the pathway and multi-professional training and awareness raising. We have a schedule of webinars to support local planning around pathway adjustments, and we're sharing good practice to support development of early intervention and prevention models routinely. For example, the Healthy London Partnership's Spot the Sign guidance has been shared with systems for local adaptation. And we're also considering how the mental health support team offer can be adapted to include overt opportunities for prevention and early intervention in schools. A suite of resources will be developed into an eating disorders toolkit to support the enhancement of those pathways. So lots of positive work is underway alongside colleagues, and that sort of summarises the work so far. And I'll just hand over to my colleague, Sarah Fellows, at this point.
Thank you very much, Charlie. If you don't mind, everyone, I'm just going to go off camera just so I can move my laptop a bit closer to me. And I'm going to try and take control, Lucy, if that's okay, of the slides. So, yeah. I think I've got control now. So thanks, Charlie, that's really helpful. And thank you, Andrew, for the lovely introduction. I think, it says I'm waiting for approval for control. So if someone can give me approval, that'd be good, if that's all right. If not, just do the next slide, if that's all right, Lucy. Oh, thanks. So there's a point for us, really, I think, which is very much around the quality of care that patients are receiving in acute environments and in paediatric environments. And this slide is a photograph you may or may not know of the hospital in France where Van Gogh received his treatment. And the point we're trying to make here, everyone, and Lucy, if you can go on to the next slide, is there is something very much about the quality of specialing that patients are receiving, you know, in mental health environments generally, as I'm sure Guy is going to come on to say, but also in acute and paediatric environments. So I think we need to think about the quality of care that's very personalised and very, very hands-on when we're providing extra support to children and young people and adults with you know, complex and or intensive needs. And this slide just flags a study that was from Norway, which focused on patients who had received treatment in care in psychiatric wards in Norway, and the importance of that therapeutic relationship with nursing staff effectively, and how much that helped and influenced their care and treatment. And the point of the link back to Van Gogh is that, you know, it's a bit psychiatric nursing myth really, but, you know, Van Gogh, when he was in mental health hospital, he received a lot of one-to-one care and passed some of his drawings onto the nurses that spent time with him, specialing him, going out into the fields, painting with him. And that's kind of gone into myth and folklore. But it's an important point really about the therapeutic contact and how that features into these episodes of care, if that makes sense. And with our colleagues in HEE, we're looking at commissioning training to support bank and agency staff, particularly who are in reaching into acute and paediatric environments and providing one-to-one care. So if you go to the next slide, please, Lucy. I mean, obviously, Charlie's, you know, really brilliantly identified many of the key points of learning from our report. Obviously, at the moment, ED and CYP terms forms a key part of pressures for admission, and there's a really helpful weekly meeting where we focus on making sure that we're prioritising correctly and giving the right level of attention and focus to patients who are waiting for beds into either adult or acute environments, paediatric wards, children and young people, obviously. And as Charlie said, we've got a Southeast region-wide implementation plan. Some services are developing all age specifications, and these I think will feature in the recovery plans that we've asked for from each system, and which will form a key part of restoration moving forward, and obviously are very much aligned to phase 4 planning. And really importantly, we need to align with provider collaborative models, both RADALT and CYP ED. We've had 2 really helpful paediatric workshops, which colleagues from specialised commissioning have been key to arranging, and I think we've all found those very, very helpful in terms of focusing again on quality, experience, outcomes, etc. for children and young people that are in acute adult and paediatric environments while waiting for admission or while waiting to go back home into the community or out into the community. And we're coming together as a group of senior clinicians to look at the issue regarding NG feeding, to see how we can develop some region-wide best practice around that. And helpfully, Charlie's informed me in the last couple of days that there is a national imperative around that. So next slide, Lucy, if that's okay. So to flag with you all, and I think most of you know, we're looking at a draft 10 key principles document, which we've drafted, which we've shared with you all, which has gone out to systems for comments and had some really helpful feedback from Sussex system yesterday regarding this. And this will focus particularly on the quality of in-reach, as I've said, into paediatric and adult environments, and think particularly about key standards, build on the NICE guidance, but then how those are localised within each system in terms of escalation and support. So how CAMHS crisis or how mental health liaison or paediatric liaison in-reach and support those patients. And that's obviously work in tandem with our draft self-harm strategy and some work we're doing around developing standards for crisis resolution home treatment. So next slide, Lucy. So I think Charlie's very much covered the key issues, but we're working with each system to develop an all-age recovery plan, close work with provider collaboratives, developing work with primary care, and obviously very close work that's aligned to phase 4 and the community transformation piece, which includes adult ED. And as part of the recruitment challenges, we have a recruitment webinar on the 29th of June, which we'll send you for the details of shortly. Next slide. There's a new adult ED dashboard. If you could just go to the next slide as well, Lucy, and then the one after that. My colleague Fifi has pulled some Southeast regional data together from this, and we may be able to share that with you very shortly. We just I'd only pulled that together in the last day or so, I'm afraid, everyone, so not in time to share today. But obviously a key development in terms of the focus on adult eating disorders. And if anyone wants any help or support accessing the information on the NHS Futures website, please let us know. And then next slide, Lucy, and slide after that. Sorry. So obviously pulling in, key to this and key to the development of the NHS LTP was the issue around learning from the government's response to avoidable deaths with eating disorders and the key recommendations, which we hope will feature as themes in all of the restoration recovery plans for eating disorders that we pull together from each system. Next slide. And this is some information regarding the current status in terms of each of the provider collaboratives, both in terms of footprint and next steps. Thank you. So again, I think Charlie very helpfully has covered most of the key issues here, but this is just a summary really for you in terms of the recommendations regarding restoration and recovery board report and where we're at with them. And again, talking to each system at the moment regarding their system-wide recovery plan, and any information anyone would want from us after this session, please let us know. Next slide, Lucy. Thank you. And this is the information regarding the Healthy London Partnership intervention, early intervention toolkit for detection and support of eating disorders, both in community and in any inpatient setting. So this slide and the next slide is information for you. And then I think that's it from me, everybody. Thanks very much for listening, and thanks again to Charlie and Andrew and colleagues for all the really hard work on the report, and thanks again to those systems we've spoken to so far in terms of your system-wide recovery plans, and look forward to working with you, as Charlie said, in the next few weeks, and align out, as I said, very much with phase 4 planning.
Thank you so much, Sarah and Charlie, and colleagues, you'll recognise just how much information there is available in these slides for you that will be following this conversation today. There's some key bits here for us to think through together. So those colleagues who are asking for information on the SEND interface for eating disorders, absolutely. There is a really crucial link, as colleagues are highlighting, both to health and justice and to social care. We've got an awful lot of that activity happening in the Director of Children's Services and Social Care for Children's Services space. And I know that Sarah and our colleague James are going to meet with the Directors of Adult Services actually this afternoon to talk a little bit further about some of the interfaces there. So those points are really important. In terms of interface with schools, that's another key point coming up, and you'll have heard Charlie talk about. We're looking at how we can adapt the mental health support team offer to be more agile in this regard, to identify need early and respond differently to those needs. Our sub-regional discussions with education through Thames Valley, Kent, Surrey and Sussex and Hampshire, Isle of Wight, Children's Mental Health Forums are our mechanism for enabling much of that. Please do keep using the chat function to pick up some of these points that you'd really like us to respond to. And if you want specific information, please don't be shy, please do ask. Colleagues, we're going to just pause for a second, and then we're going to move into the content from Dr Guy Northover, who has, through his clinical leadership nationally, been analysing what the opportunities are for us to intervene and prevent some of this trajectory in the journey of children and who then become adults, much more effectively looking at hospital settings and community settings particularly. Guy, it's a real pleasure to welcome you today. There is one thing that Guy will do, which is he'll be quite direct with us because we've asked him to be, about the things in our system that are fine, but the things in our system we could look at together and work very differently on. Now, this will include a conversation about the current approach to restraint, which we appreciate has mixed kind of clinical perspectives on, but we are worried about. So please do hear Guy out as he talks through his analysis in this report. Guy, you're most welcome.
Hi, thank you very much. I'm just, have I successfully shared my screen, or am I sharing?
You have. No, you have. Well done.
Is it just sharing the slides, or a little bit more than just the slides? Because on my screen here, it appears I'm sharing the wrong thing.
I can see your slides, Guy. That's what I can see this end, and no more than that.
Brilliant. So you can't see underneath that where it's going to the more actions and the numbers?
Afraid not, no. Just your slides. All right. Fantastic. Thank you.
So hello everyone. So my name is Guy Northover. I'm a child and adolescent psychiatrist working in Berkshire. I've got a few other things I do as well, which I'll just quickly sort of mention. So I co-chair the digital clinical reference group for the CAMS Tier 4 clinical reference group. I'm the finance officer for the Faculty of Child and Adolescent Psychiatry, and within Berkshire, I'm also a lead clinical director, and I'm the chief clinical information officer. So it's always embarrassing when something goes wrong with digital, when you've got those sorts of things. But what I wanted to talk about today was what we found from the Getting It Right First Time work that we did. You'll be glad to know that an awful lot of what we learned is actually exactly what you've just heard. So you know, it's always good when we've got a degree of consistency. Right. Let me see. Have I moved the slide on successfully?
Not yet, no.
Oh dear. See, I thought something was going to go wrong. Hang on. This is what happens when you identify yourself as a Chief Clinical Information Officer. Right, how's that?
Yeah, unwarranted variation at the moment.
Fantastic.
Right.
Okay, so we've got that bit right. So getting it right first time is around unwarranted variation, because we actually know that variation exists everywhere, and we have to be clear whether that variation is positive or negative. And historically within the NHS, we've always assumed that variation is negative, but of course that's not the case. And actually, if we're trying to develop better services, we need to look at that variation and then replicate that which is working well. GIRFT is also very much around quality improvement. It's not about quality assurance. So it's not around identifying the worst services and saying, hey, stop. It's about identifying how we can improve all the services as we move forward. What is interesting, however, is one of the findings from the work we did was around quality improvement. And out of all the CAMHS Tier 4 inpatient units, we identified 23% of them were probably using a clearly defined quality improvement approach, whereas the rest were maybe using QI, but more likely actually weren't. So an example of a non-QI approach would be using a national audit to say the national audit has identified we're not doing very well here, let's put an action plan around it. That's not quality improvement. Quality improvement is where it comes driven up from the clinicians on the floor to think about what the real root cause of the problem is and put in place those countermeasures. So GIRFT, it builds on all the other initiatives and learnings over the years. It's not a standalone project. It's about reducing the unwarranted variation. Within orthopaedic surgery, where this started, they identified that the implementation of GIRFT and looking at unwarranted variation saved orthopaedic surgery nationally over £200 million. Of course, in terms of child and adolescent psychiatry, that's not sort of the aim that we have here. We're certainly not looking at saving any money. We're just looking at how we can use the money more effectively. It uses all the national data sets that we could find, and along with a supplemental questionnaire which was sent out, we then developed some data packs which were sent out to trusts. The data packs were developed at a provider collaborative level because the urgent care pathway is so complex, looking at an individual organisation doesn't work. And then we've been undertaking deep dive visits, which is where we virtually go to a provider collaborative and have a conversation around the data and what might be underlying it. So we're looking at urgent care and crisis pathways. It's general admission units only. General admission includes general admission, eating disorders, and the high dependency units attached to a general admission unit. We're not looking specifically at children units, and the recommendations can't be assumed to be right for children units because we didn't look at them specifically, and of course some of the data from children units would be quite different. We extended it out to crisis services, intensive community support teams, and also to the specialist community teams. Intensive community support teams is my own phrase, and it's for those services that are more specialist than our specialist community teams, but are there to avoid somebody going into a crisis rather than manage the crisis when they're there. So the majority of eating disorder services and early intervention psychosis services would sit within that group. The independent sector was fully engaged right from the beginning, which is absolutely fantastic. So we've completed the vast majority of the deep dive visits. We've written a national report, which is just getting sign off at NHS through NHS England Senior Leadership Group. There's 20 recommendations, each of which has a suggested action plan. As the senior leadership team hasn't completely signed it off yet, I'm actually not presenting the recommendations as they are because we have to make sure that what comes out is the final version. And we are now developing gateway metrics, which will be held in the model mental health. They'll be linked to the GIRFT findings. So moving forward, every organisation will be able to see where they are in terms of their position within these metrics, which have been identified as the most important metrics to drive quality improvement and effectiveness and efficiency. So I've got a first question. I am using a Menti here a little bit. I'm not great when it comes to Mentimeter, and Richard's been trying to help me out, but hopefully Richard's going to be able to post a link to a number of questions on Mentimeter. And if you're able to answer those questions, then we can come back hopefully and have a look at the results of that either within the presentation or at the end. What I would say first of all is, do we actually know what we're treating in the community? And I think that's a question which we should be asking locally, but also nationally. So do we have the right data collection processes so we know exactly what it is that's coming into the specialist community team? When it comes to eating disorders, we can be pretty clear on an eating disorder because we've got specialist services which have the diagnostic routes within them. However, even within eating disorders, are we clear when we're treating an eating disorder or an eating disorder with a comorbidity? Are we effectively recording those comorbidities? I can be pretty sure that we're not when we look at the data. So this is looking at 2018-19 data from the MHSDS. We can see on the England average, across the whole country, we're very, very poor at actually recording diagnosis. If we're looking at a couple of examples from the deep dive visits, we are probably even worse than the national average when it comes to recording diagnosis and flowing that up to the MHSDS. I always find it quite interesting to look at psychosis, because psychosis is normally the best recorded diagnosis that we have in the community. I don't know again whether that's easy to record because it's easier to diagnose, or whether it's because early intervention and psychosis teams are more likely to be taking an adult approach to diagnosis and treatment than child and adolescent psychiatry. However, if we identify the psychosis band within just these two organisations, we can see a significant difference, or these two provider collaboratives, we can see a significant difference in the number of people getting diagnosed with psychosis. And here we can assume that this is an underreporting, because we can be fairly consistent in terms of the levels of psychosis diagnosis. So it does seem as if as a region, reporting on diagnosis is something we need to improve. This is just looking at it in a slightly different way. And again, it suggests that the best trusts are recording a diagnosis in around about 50% of young people, the worst performing trusts in around about 1%. We often think that inpatient units will be better at recording a diagnosis than community teams, and that's certainly the case, but it's still not great, to be totally honest with you. We have here an inpatient unit that's recording diagnosis at around about 18%, and even the top performing inpatient units are only recording diagnosis in around about 90 to 95%. What is interesting from this is that these red bars are independent providers. So independent providers are, on the whole, much better at recording diagnosis than NHS providers. It's difficult to know what the reason is behind that, but there is certainly some variation there. My next question, you can see my Mentimeter questions here, which I was going to cut out of the presentation but haven't, is so we don't really know at a national level what's coming into the community to be treated. So the next question is, do we actually know what we're doing when young people come into the community? I've already given away my answer, which I suggest that we probably don't. So how can I say we probably don't know what we're doing in the community? So I'm going to start off looking at the I'm going to start off by just looking at the commissioning, and we can look at the commissioning through the funding that's coming through and what's being provided within the trusts. So first of all, if we look at this nationally, these are just some trusts from the South East region identified in red, to be honest. If we look nationally, we can see the CCG expenditure on children and young people per capita has a huge variation. I mean, it's enormous. It's far, far greater than it is for any other mental health condition. So there is something here that suggests, from a commissioning perspective, we don't really know what it is we want to be providing. If we look at what's happening to the providers, so this is looking at the community clinical and non-clinical work time equivalents. So this, of course, is slightly different. The CCG expenditure will cover expenditure that's going to an NHS provider, independent providers. This is going to cover mental health expenditure that's going to the acute hospital and cover a whole load of things. This is looking at what's being provided by the mental health trusts for children, young people, mental health services. The metric I chose here was clinical work time equivalents, and again, there's a massive variation here per 100,000 population, from over 300 clinicians per 100,000 population down to very, very few. We can guess that these are specialist services, but the variation is difficult to explain away. It suggests again that we don't really know what percentage of trained professionals we want working with our patient group. It's also quite interesting if we look at the expenditure against the number of referrals. So along the bottom, we've got the expenditure per capita, which is from the CCGs, and this is the number of referrals coming into the community mental health team. And the more that it's spent, the more referrals that come in. So I suppose that's pretty good, isn't it? I mean, it's nice to see that if we spend more money with an area, then we actually see more people being treated. If we look at the relationship between expenditure per capita and the number of admissions into a Tier 4 inpatient unit, that relationship changes slightly. So you get far less bang for your buck if you're trying to avoid Tier 4 inpatient admissions. However, there is still, within these two organisations, within these two provider collaboratives, a linear relationship. The more you spend as a CCG, the more young people are going to be admitted into a Tier 4 unit. So again, there's a question here, is that good or is that bad? because you would, in some ways, you would hope if you're spending more in the community that you would be decreasing the number of people who are presenting in the most significant challenges and difficulties. But we're not really seeing that. However, what it might mean that actually we've got some trusts that know that they're working in an area of very significant deprivation who need to be increasing the funding at all levels of care. At a national level, we see a slightly different relationship. So at a national level, we see that the less that is spent by a CCG, the less admissions that they will get into a Tier 4 unit. So again, that's quite difficult to explain, and to me suggests that we don't really know what the best clinical model is in the community, or what it is we're actually aiming to achieve by investing in the community. Now, there is time for questions at the end, so if anybody wants to challenge my data, please do, or challenge my interpretation, because the whole of GIRFT is around that conversation. If everybody sits down and listens to me talk, you'll go out hearing my views, and then you'll have to assume that I'm always right. I saw Susanna Yeoman on the in the chat, and Susanna knows that I'm definitely not always right. So the other thing is, so we're not sure what the community clinical model is or what's best. What we also don't know is we don't know what works, because we don't record, or at least we don't flow, outcome measures up to the MHSDS. So the best organisations, what I chose for my marker was a paired outcome measure. Did we do an outcome measure for a young person when they first were in contact with services? And did we repeat that measure when they were discharged to see if there's an improvement? Nowhere does that 100%, and only a few organisations are actually able to do that with more than 50% of the young people coming into their organisation. So far, what it appears is that we don't really know the diagnosis of people coming into community services. We don't really know what it is that we're doing when they're in the service, and we don't really know if they're getting better. What we do know is we keep on asking for more money, because these kids are because we seem to be getting more and more demand. So I think we've got a few questions that we need to be asking ourselves. If we're asking for more money, can we be absolutely clear that we're investing it in the right places and that the outcomes are good? So my next question is, do we have clear multi-organisational pathways? Now this is looking a little bit at the eating disorder question. And this is within the Mentimeter. Again, I've got no idea how that's going. The question is are we linked up appropriately with the acute hospitals? And do the acute hospitals look at mental health patients in an effective way? One of the reasons for the importance of this is the next couple of slides I'm going to show. So these slides are looking at the number of young people who presented to accident and emergency within 24 hours of being admitted into a Tier 4 inpatient unit. Each of these bars here is an NHS provided Tier 4 inpatient unit. We weren't able to do this with the independent sector, because the independent sector data was very, very complex, because they admit from so many different hospitals. But what we can see is that within the last 24 hours, on average, 40 to 50% of the young people, so 40 to 50% of young people who are admitted into a Tier 4 unit are admitted directly from a physical health ward or from accident and emergency. And that's a huge amount. And it makes me wonder whether we are putting the right interventions in place when they were in the acute hospital. Was there an opportunity to provide a different intervention that may have meant that an admission was not the best option? Again, these arrows are just looking at provider collaboratives within the South East. We have got, and even with this, we've got some very, very stark variation. So if we're looking at this inpatient unit here, only 10% of the young people admitted to that inpatient unit would have been coming from an acute physical health ward or accident and emergency. Whereas here, we're looking at around about 45%. So the question is, which of those is good and which of those is bad? The data certainly doesn't interpret which is good or which is bad, but it certainly says there's something quite stark and quite different going on here, which should probably be looked into further. Some of these organisations right down the end here are organisations that the NHS provider doesn't have a Tier 4 adolescent inpatient unit, but still young people were moving from accident emergency or a paediatric ward into the adult ward from that trust. So this is indicating a different issue and a different problem. I also think it's very interesting if we look a step further and we actually look at how many of the young people who are admitted to a Tier 4 unit actually present to an accident and emergency within the 6 months prior to admission. And we can see here we're running much, much closer to 100%. So again, almost every young person who ends up in a Tier 4 inpatient unit has been through accident and emergency in the last 6 months. So again, are we looking at missed opportunities here to provide a different type of crisis intervention? We can guess actually that an awful lot of the young people going through the physical health wards have got an eating disorder, because more young people are admitted directly to more young people are admitted to a Tier 4 unit who have spent time on a physical health ward than just going to accident and emergency. And here within the southeast, we've got one Tier 4 inpatient unit here where 100% of the admissions had been admitted to a physical health ward in the last 6 months. So there is that real question: is something going wrong with the support that's being provided on the paediatric ward that means we're missing an opportunity? I've raised this issue at all the deep dive visits, and we've had a number of concerns raised, and a number of people raising or indicating what they feel might be behind this. So first of all, we've had concerns around the legal status of young people on physical health wards. So there's been young people who it appears that they've been deprived of their liberty, but they don't have any framework around that. We find that eating disorder teams in particular feel that when there's a decision by a paediatric team to NG tube feed, that there isn't a comprehensive or holistic plan. More recently, an issue that's been raised here is that the marzipan guidelines push paediatricians into NG tube feeding young people that perhaps we would choose not to. So an example of that would be somebody with ARFID. If they're hitting criteria on a marzipan guidelines, then they're probably going to be NG tube fed, and that's almost certainly going to drive a Tier 4 admission. However, it may not actually be clinically the right thing to do. And I'm saying may there, I'm not saying definitely. We've had a deep dive visit where there were paediatricians present, and their concern was when a young person was admitted onto their ward that they felt that the mental health input was very, very sketchy. The mental health team felt that their input was very good. So again, there's that mismatch of expectations around what is it that should be provided and what is the best provision for a young person on a paediatric ward. And then there was the final part, which is the lack of recognition of the paediatric team's role in admission avoidance. So again, does that paediatric team understand that a young person with an eating disorder being admitted to a Tier 4 unit may do worse than a young person with an eating disorder who's able to be supported in the community? The paediatric team we've spoken to seem to feel quite strongly that once a young person is presented to a paediatric ward, that they're waiting there for a bed rather than it being seen as an opportunity to avoid an admission. Right, so I'm going to move on to the inpatient services, just to see if we can answer this next question, which is, are we providing high quality inpatient services? What I'm going to look at in particular is the use of restrictive practices. So what I've done is I've identified some Southeast region inpatient units. I've also anonymized them because I've decided to be friendly, but they're all color coded through the next set of slides. So wherever you see this green, the green bar, that's the same inpatient unit. So the first thing I'd like to point out here in terms of variation, we've got a yellow unit that uses relatively high levels of seclusion. So one of the questions is that good or is that bad? What's interesting here is the unit that uses relatively high levels of seclusion uses much lower levels of restraint. So is this actually a unit that is being proactive in terms of using appropriate seclusion to avoid restraint? It's also a unit that's probably reporting prone restraint correctly. The alternative unit here, the red unit, uses high levels of restraint, high of prone restraint, high instances of all restraint, and relatively high instances of seclusion. These are all general admission units. So there's a question here: how is it that you can have in the same region 2 units that are providing such different levels of care? And this is just a chart here as well, which is looking at the it's looking at restraint, and it's comparing restraint for 10,000 occupied bed days for children and young people against restraint for 10,000 occupied bed days for adults within the same trust. And we can see, first of all, that you are 5.7 times more likely to be restrained if you're a young person than if you're an adult. In some organisations, you're 27 times more likely to be restrained as a young person than an adult. And I would challenge anybody to explain that away as a necessary difference in terms of intervention. The other thing that this chart shows to me is that it's more of an exponential chart. So this isn't a direct relationship. The more likely you are to restrain an adult, you're proportionally more likely to restrain a child. So there is definitely a cultural issue going on here as well. I personally find it very, very difficult to understand why we can justify restraining children more than adults. And I think that it's multifactorial. Again, in deep dive visits, we have conversations around how quite often we end up with young people being admitted who the inpatient unit would prefer not to. We have challenges when it comes to young people needing a higher level of care. So we know that it's very difficult for a young person to move from a general admission unit to a low secure unit, for example. But I have also heard that kids need restraining more because they need to have more boundaries put into place. So there's a lot of work that needs to be done. And we also have the same relationship with prone restraint. You're 2.7 times more likely to be restrained prone as a child than as an adult. So my answer to the quality is I think we've got a long way to go in terms of improving the quality. So this is the only recommendation I've put down because this is the one which often leads to the most discussion. The question is, do we have clear inpatient models? The recommendation coming out of this is around length of stay. At the time of the at the time of the data collection for this GIRFT report, the length of stay was 65 days, the average length of stay. And what the recommendation suggests is that we should be reducing the proportion of young people who are having very long stays on the unit. And I put 60 days as the average here because to be totally honest with you, if we start moving beyond 2 months, we start thinking to ourselves, what is it that we're doing for a young person who's staying on the unit for more than 2 months? We know that the reasons for long stays are multifactorial. We know that there needs to be appropriate community services for a young person to be discharged to. We know that we have to be assured that a young person who is presenting with high risk has a crisis service. But the final part of it is we also need to link length of stay and admissions to clinical outcomes. So what is the point of discharge? What is it that we're actually aiming for? The reason why this is important is actually a financial impact. If we were to reduce the length of stay in those units whose length of stay was above average to average, so the average length of stay, so the average length of stay, so it's reducing this would reduce the national length of stay to 57 days. We would be saving the equivalent of 144,000 bed days, which is the equivalent of 300 beds. If we were to reduce down to the best quartile, then we'd be saving almost 600 beds. And when you think that the present bed base for child and adolescent psychiatry across England is 1,300 beds, we would be freeing up 600 of those beds if we reduce the length of stay down to what is still above the national average for the adult length of stay. So the question here is not, have we got the length of stay right? The question here is, are we putting the resource into the right place? Do we really want to be building more beds for the clear demand that we have for inpatient beds at the moment? Or do we want to be investing in the community so the length of stay comes down and we don't need to build those new beds? And I think that's a very important question that needs to be thought about. I mean, another fact is the cost of the average inpatient admission for a child and young person is the same as 100 community interventions for children and young people. I'm just going to run through again some of these charts. I'm just highlighting the green inpatient unit because it's just quite interesting. So the green inpatient unit has got quite a long length of stay here. The length of stay data is really skewed. It's much more difficult to read because of this inpatient unit here, which absolutely does have an average length of stay of 312 days. So it's about how do we how do we follow the impact of this mean length of stay for this unit and what might be behind it. So we can see that the length of stay is long, so the cost of the admission is long. If we look at that in terms of a chart, that makes sense. So the longer you stay in an inpatient unit, the more expensive the admission. This is particularly notable for the eating disorder beds, so the eating disorder units nationally. They have a much longer stay and turn out to be much more expensive units. Our green unit sits here at the moment. So the next thing when we're thinking about length of stay and the effectiveness is, and the cost of an admission, what's the cost per bed day? And here we can see that the green unit is one of the cheaper units in the country. However, being a cheap unit doesn't mean that it's cheap per admission. It's one of the more expensive costs per admission, but cheap per bed day. So have we got the resource right there, or have we got a commissioning model that's pushing us into reducing the cost per bed day, which may also subsequently be changing or reducing the quality of care? And again, this is what we see here when we look at this. So we're looking at the mean length of stay across the bottom and the cost per bed day going up the side. We have some very, very interesting units that are able to do both. We have some units which are quite expensive, but able to have a good cost per bed day, but we've got a whole set of units that are cheap but are actually resulting in poor outcomes for the young people. And it's also again notable here that the eating disorder units are all clustered at the wrong end of this graph. Eating disorder units as a whole are demonstrating a relatively cheap cost per bed day, but a very expensive and a very long length of stay. One of the explanations behind this is the number of staff that are employed. So yes, so we can see here that the green unit has got less than average number of staff employed. However, there are some units that have got less staff here. If we actually plot the clinical work time equivalents per 12 beds against the mean length of stay, there's a very, very clear association. Which I haven't done the statistical analysis, but I would be convinced that this is statistically relevant, that indicates that the more staff you have, the shorter the length of stay. This is not looking at the qualifications of the staff or the experience of the staff. This is just saying the more staff you have, the better. When we speak to young people on discharge from inpatient units, one of the things that is quite commonly heard is the worst thing about being in an inpatient unit is being put down in front of a TV with nothing to do in an evening with a load of kids who are really struggling. We find that kids talk about, on occasion, escalating their challenging behaviour because they've got nothing to do on an inpatient unit. It is, of course, multifactorial, and I'm just pulling two comments out of the air there. But there's something which suggests that having enough staff to maintain meaningful activity throughout the day is not just an important factor when it comes to staff morale, it's an important factor when it comes to length of stay and the improvement of young people. The final chart around average length of stay that I want to show is around stratification of data. So again, I've identified this green unit. So stratification of data is making sure that we're not just looking at an average, because an average doesn't allow us to see where the real challenge and difficulty is. So what we've done is we've broken it down to look at the proportion of discharges in 4 different groups. The groupings are not quite right. We were using NHSBN data for this, the national benchmarking data, and we weren't able to break it down in a different way. We're using a funnel plot, so the mean runs along the middle, and then this first line is 1 standard deviation from the mean, and this is 2 standard deviations from the mean. If you're sitting more than 2 standard deviations from the mean, it means you're doing something very, very different. This unit here, for example, runs a 72-hour crisis admission process, where a young person who's in a crisis, who may or may not be presenting with a mental illness, can be admitted for 72 hours. So quite understandably, the proportion of discharges less than 7 days is very high. Our green unit is not doing very well at all, to be totally honest with you. Okay, it does do pretty well when it comes to 7 to 28 days. Sorry, pretty poorly when it comes to 7 to 28 days. That's where it has the least number of discharges. And it's doing incredibly poorly when it comes to discharges over 60 days. So this is a unit that has a culture of holding on to young people for more than 60 days. And to me, that would need a real understanding as to why that's the case and what benefits this unit feels that it has by holding a model that's really quite different to what we see nationally. What else is quite interesting from this unit, though, is that actually in terms of its maximum length of stay, it's not doing too bad. Well, I was going to say it's not doing too badly. Its maximum length of stay is one young person was discharged between 17 and 18 who'd been admitted for a year. So I still do wonder about what we are providing in terms of care for young people who may be admitted for as long as 3 years, but its very long length of stays are less bad. The other interesting question is around the use of leave beds. So what we're looking at here is we're looking at the bed occupancy levels for the inpatient units, and then the blue is the bed occupancy excluding leave, and then the red is bed occupancy including leave. So the first thing to note about this is the average bed occupancy rate in 18-19 was below 80%. Now, this always comes as a surprise because people working in inpatient units feel that their units are always full. But some of the reasons for the lower levels of bed occupancy are issues such as the unit perhaps being closed for closed to admissions for a few days. It might be that some beds are opened halfway through the year, which would then skew the end of year results. But I think it's also the pressures within the inpatient unit make it difficult to realise that at times the units are less than fully occupied. The final thing to be really, really clear about this is that we staff inpatient units for 85% bed occupancy. So when we're seeing above 85%, we need to be thinking to ourselves, have we got the staffing levels right? Because we probably haven't, because we should be staffing for 100% if the unit is always 100% full. Units such as this are interesting as well. Again, if we're thinking about the cost of the inpatient units, where we're putting the resource, why is it that we have units which feel that maybe 40% of the cost of the unit is being spent on patients who are actually on leave? So what is it that's happening there? Where's the breakdown between the link between the inpatient unit and the community, which leads the inpatient unit to feel that they need to be providing this additional care and support for a lot of young people for a lot of hours? When again, this is not something that is necessary when we look at the data. We do have to link it to outcome data. This isn't linked to outcome data, so I can't tell you whether actually these units are providing better outcome or not. But what I can say is when we're looking at that crisis model, we certainly don't have any consistency or understanding around what's the best model and what's the best use of leave or our beds. I just wanted to go a little bit into workforce. I've already shown you this slide here, but it's just indicating that when we're looking at our general admission beds, the number of staff, the average number of staff is 38.5 staff per 12 beds. If we're looking at the eating disorders, the average number of staff is actually less. We also notice here a significantly lower number of staff within the independent sector than we do within the NHS. Yeah, so I mentioned the bed occupancy issue. The Vacancy rates at the time of the data collection was 19%, with a mean of 19%, which is massive, really, really huge, which again always worries me about our plans to build more inpatient units, which is where are we going to find the staff to staff these units? When I've done the deep dive visits, vacancy rates do appear to have improved, but units are still reporting significant challenges with recruitment. We also noticed variation in sickness. So one unit in 1819 was reporting 14% of its staff being off sick. So how is it we can address this to really try and provide that high quality care that we need? The staffing levels, very, very inconsistent. With a variation between 21 work time equivalents per 12 beds to 80 work time equivalents per 12 beds. When we're looking at 80 work time equivalents per 12 beds, that's usually an indication that they're running a day program as well. But again, it suggests that we really don't know what that best crisis model is. And actually, how do we start identifying what the best, most effective, most efficient model is? Providers really can't explain, well, providers at deep dive visits found it difficult to say why two units had very different models and were unlikely to be collecting the data other than the length of stay data to indicate which of the models was best. So again, we really do need to be thinking around that outcomes data so we can really start driving the best care and really identify which variation is good and which is variation we'd want to remove. So some other factors we identified at deep dive visits. Units were very clear that the therapeutic milieu was very important both to staff well-being and to shorter admissions. So units which had more control over who was going to be admitted and who wasn't seemed to do better. And this was usually led by a very strong provider collaborative bed finding team who were able to say, okay, this unit here has got 8 16-year-old girls who are all self-harming in significant ways. We probably don't want to admit this 16-year-old girl with autism who's not self-harming yet onto that unit. We find a slight benefit, a shorter length of stay for all young people for units that admit all presentations, including complex eating disorders. So those trusts which have a standalone eating disorder unit and a general admission unit overall has a longer length of stay than those trusts which only have a general admission unit and will admit all their eating disorder units and their complex EDs and will NG tube feed on that unit. So there's something around the eating disorder units that drive up length of stay for young people with eating disorders, but actually also in some ways drive up units that don't have eating disorder admissions, drive up the length of stay for those young people who are not presenting with an eating disorder. The data on this to me is convincing, but it's not at the level where I'll be wanting to put it into a paper and have it as the absolute truth. But I think when you are looking at the eating disorder pathway, I think it's really important to think now, what is the role of this specialist eating disorder unit? Does this specialist eating disorder unit have all the skills for the young people that it's likely to be admitting? Does it have the skills for the comorbidities around the eating disorder young people? Or would somebody with emerging personality disorder, an autistic spectrum disorder and an eating disorder do better in a general admission unit which has got a program dedicated to each of those conditions? Units that admitted emotional dysregulation and self-harm report the least staff satisfaction. And these were units that not only would report as poor staff satisfaction, the staff felt that they were often escalating young people to PQ beds and felt less able to manage some of the challenging behaviours than other units. And again, whether that's because of the impact that managing young people with such presentations has on us as people when we're trying to be when we're taking that caring role, and whatever we do doesn't seem to support the young people and make them feel better. It's a very, very challenging and difficult situation for staff to be in. So what I sort of brought out of this in terms of recommendation is that we need to have very clear therapeutic models within the inpatient units, so we know what it is young people are being admitted for, We know what therapy they're going to get, and we know what the expected outcomes of that. It's no point us just saying we've got these therapies. It needs to be very clearly identified and staffed so that we have the model in place. And the final bit, which I feel very strongly about, is units should be commissioned based on the provision of the therapeutic care and the outcomes expectations, not a cost per bed day model. One of the things I haven't gone into, which I've got a lot of data on as well, is the pre-admission process. And we know that units with a shorter length of stay have a very, very robust pre-admission process, which goes to the extent of almost having a CETR for every young person prior to their admission. And part of that process is thinking, what can we do to avoid this admission? And if an admission is needed, what are the outcomes that need to be achieved for the community team to feel confident of taking that young person back? There's a strong feeling that there's a lot of siloed working, and when a young person goes from a specialist community team to a crisis team, that there's a reformulation of the difficulties. Then when they go from the crisis team to the inpatient service, there's another reformulation of the young person's difficulties, and trying to link all of that together so the young person doesn't get multiple assessments, multiple different diagnoses, and multiple different treatment plans is really important. Right, this is my final slide. I think I'm going to finish on time. That's amazing.
Well done, Guy. Yes, very good.
So I just wanted to really thank the NHS Benchmarking Network, because they did an awful lot of the data collection and data analysis. The NHSC policy team have been engaged right from the beginning. The Specialist Commissioning Team and the Tier 4 Clinical Reference Group have provided a huge amount of support into this as well. And again, one thing I also want to say is the vital recognition of the ongoing research within child and adolescent services, identification of the best models of care. If we don't bring the quality improvement, the research and the governance all together, we're never going to find ourselves improving. And that was my last slide, so I can now stop sharing.
Guy, that's excellent. Thank you so much. You'll have, when you stop sharing, you'll see just how much there is in the chat, Guy, in response to what you've provided so far. And colleagues, it's really important to say that on the Menti system, we've been picking up, because there's so much activity, we've been picking up the key themes. So just to summarise, the points that Guy has made about the use of restraint and the disproportionate use of restraint on children between 5.7% and 27% more likely than adults has led to a lot of conversation. There's particular points there around, please could acutes be supported with training to de-escalate situations with children. So Guy, that's certainly something you'll want to comment on, and HEE colleagues with us today will want to also be noting down and commenting on, and I know we're doing some work on that. Two other key themes, Guy, for you just to kind of think about while we turn to the questions that are arising. Social care and CAMS and acute join up. So you've mentioned some of that in what could the CETR style model be, and we've got quite a lot of that in South East, but what could that look like? But colleagues are pushing slightly further and saying there's a whole host of information around neurodiverse, LD, etc., social care placement pressures that we could be putting alongside the analysis to build a fuller picture. And that takes us to the next key theme that's coming up from Menti colleagues and Guy, which is that driving towards investment in the community is absolutely where everybody wants to go. Investing in the right evidence-based community models and investing in training that skills the entire workforce to work in that way are top of the list of things that people want to see. Integrated multi-professional as well as multidisciplinary models is coming back very strongly. So colleagues, time now for questions and comments to Guy. Colleagues, you may want to just pose those, raise your hand if you'd like to speak directly, or pose those as a specific question in the chat. Either is fine. Guy, while colleagues do that, do you want to respond on those three kind of headline points I've just summarised there? The
integration with social care is absolutely crucial. There's no question about it, and how we do that is so based on trust. And I think that's one of the really important issues is we have to trust social care to be great at doing their job, and social care have to trust us to be great at doing our job. I think when we start developing that trust, we really start developing some fantastic systems. So Cheshire and Wirral have they have 3 safe beds. So these are 3 beds that are attached to the inpatient unit, but a young person isn't admitted to the inpatient unit, they're admitted to a safe bed. The safe beds are for 72 hours only, and they're for young people who, for whatever reason, can't be going home, maybe because they are threatening self-harm or suicide, but are not presenting with a condition that is wanted to be admitted into an inpatient unit. In the 3 years that they've had these 3 beds, 1 young person has required an admission into the inpatient unit. And that's because of the strength of co-working that the inpatient unit has with the local authority, so that when a young person is admitted there, be it a Friday night or a Monday morning, to really start thinking about what's the needs of this young person, how can we find them the right placement, how can we ensure that the crisis team is providing them the right support. So it is absolutely possible, but to me it really does come down to that trust, because I'm sure there's lots of clinicians who work in inpatient units who would be thinking, goodness me, if we open 3 beds for those sorts of patients, they'd be full tomorrow and we'd never get rid of those young people.
Thank you, guys. So in this session today, we've had a number of directors of children's services, a number of leaders in social care also join us today, which is a demonstration of the commitment in the region to work in this way. In terms of questions, I'm going to just take some hands now, Guy, if that's okay. So Sarah, did you want to go first?
Thank you, Andrea. I just wanted to say thanks very much, Guy, and I'm sorry I had to drop out for 10 or 15 minutes. And I guess when I heard you speak last time, the point that really spoke to me, and I think the CETR point probably plays to this as well, is thinking about how we use the adult, acute and paediatric wards as an opportunity. So I think you used the word opportunity. So how is this an opportunity to do something different and to avoid admission if at all possible? That was something that I think really landed very well with me. And I think, sorry to labour the point, colleagues from NHS England and Improvement, but I think that's what we're trying to do with the systems in terms of principles. So how can InReach into these environments support? I mean, there's some very critical situations. Nobody needs me to go into all the detail. You all know it way better than I do. But there's some very critical situations occurring. So, you know, how can we support those critical situations that are very impacting on the experience of other patients in those environments negatively? And then, you know, I guess the bit about how do we then use that to avoid admission? And I think to use the CETR process in that, personally, I think it'd be really helpful. I see that Andrea's put a note in the chat about, you know, the resource required to do that, though, to extend that.
Sarah, thank you. John, Guy, apologies, your response, and then we'll go to John. Thank you, Sarah. So
Sarah, it is definitely more than InReach and support. So again, if we think to the provider collaboratives and the deep dive visits that I've done, so I've done 13, I've visited 13 of the provider collaboratives across the country and shown them their data. And this is a conversation that we've had at almost every one of them. But those mental health teams, and particularly the eating disorder teams that have got an employed paediatrician within the team who also works within the acute hospital, appear to have better processes than those hospitals and trusts that don't share a paediatrician. So to me, it's something around culture as much as it is InReach. So how do we support the paediatric wards? I'm using paediatric wards generally because I'm too lazy to say paediatric wards and acute adult wards in those cases where a 16-year-old is admitted to an acute adult ward. But hopefully everybody knows what I mean. But it's about how do we make sure that we share the culture? How do we make sure that the understanding of what these young people are going through with an eating disorder when they're admitted, and how do we help the understanding that admission should be avoided if at all possible? Or an admit, that's probably going to, hopefully somebody will come back to me on that one on the chat, because it's not avoiding admission if at all possible, it's making sure that an admission is only done when the admission will provide the best outcome.
That's brilliant. Thank you, Guy. And I have no doubt the chat's going to respond now. Thank you. We've just made a commitment to share those good practice examples that you've highlighted as well, please, Guy, with others, so that we can look at the models. John, our colleague who's Chief Exec in the voluntary sector. John, you're next.
Thanks, Andrea, and thanks, Guy. Very, very interesting presentation. A couple of things I think it's important probably to distinguish when we refer to social care is that are people talking about the third sector, or are they talking about social care? Are they talking about third sector organisations that are commissioned by local authorities? There's some key differences. And I think some, the data you presented, obviously it's data that is accessible to you, but it would be really interesting to see of those young people who are admitted, how many of them are receiving support by third sector organisations. And this is the thing when it comes to community investment is most of these young people, very complex young people, will be supported by charities or other organisations in their local community, and that's where they'll spend most of their time. And that's where we need to direct the training. Most charities that I speak to are, like the NHS, seeing increasing numbers of young people presenting with disordered eating, self-harm at a much younger age now as well. And they're absolutely crying out to receive that training and education so that they can work in a very preventative way with these young people. So I think when we're looking at the data and all that, it may be that those units with low admissions have a very well developed third sector or community resource, which is helping. So it's fed up me banging on about the third sector, but I think we have a workforce there ready to help. And
John, I absolutely love hearing what you're saying, because it is so true. Okay, and it is so important that we look at pathways is the wrong word, because we've moved beyond pathways, but we look at a whole system approach. We don't look at siloed approach. Siloed approaches leads to poor care, it leads to very expensive care, and it leads to worse outcomes. The two words I absolutely hate is referral and discharge, because you're never discharged from healthcare. Well, maybe if you die you are, but other than that, you're never discharged from healthcare. And why should somebody have to be referred from one service to another? We should know exactly what those trigger points are for somebody to move up or down that path of healthcare. And within that, everybody is involved. Social care is involved. Third sector is crucial. We have to make sure that we're linked together and everybody has the right training and the right support and the right knowledge to know when actually it's time for somebody else to start providing some additional support. The Thrive model does start working in that way, and I do like the Thrive model. Also, John, one of the things that we're starting to do in Berkshire, I've also got to bring in data, I love data, is we're looking at population health management. So we're looking at our population health data to start seeing, can we identify those young people who have presented late with an eating disorder? If we look at the last year's data and we say, okay, this is the cohort of young people who presented late. If we look on our population health data, we might be able to see that they were in contact with a GP more frequently. We might be able to see that they were less in contact with education. Within some parts of Berkshire, we can even bring some of the third sector engagement into that slowly, because again, it can be a little bit more difficult. So at some stage, we're going to be able to hopefully say, goodness me, look at these 100 people in the community who have not presented, but they are people who are hitting our trigger points. Let's go out and provide some support to them now, or let's at least send out a screening letter to see whether these are people who need a different level of support. I've gone off on one, John, but that's
no. And I think I would make a plea as well. You talked very interestingly about the tier 4 and the issue of behaviour escalation because of boredom. I would encourage people who are commissioning those units to think creatively about the resources in the community that actually would reach into those units. The charities, third sector organisations that are not necessarily CYP specific, but actually do drama and arts and things like that. That actually is a low cost service that can complement the professionals that work in those units.
When I was
Guy, I'm going to, just because there are other people who would like to speak to you too, if that's all right. I know you could talk for hours. John, you'll be coming back to visit us at some point soon to talk about voluntary sector role in this whole dynamic of particularly complex children and young adults. So we'll hear more from John a bit later in our series. there's a key question here, Guy, around guidance on briefer admissions and demonstrating good outcomes. It's come from Kamala in Sussex. I wanted to say, what is there that could be drawn on in that regard? Did you want to, Kamala, hello, did you want to just kind of frame your question better than I've just summarised it?
Yeah, I couldn't actually put my hand up, so that's why I did it in the chat box. So, hi there, Guy. I'm clinical lead of the Sussex Family Eating Disorder Service, up to 18 young people. We don't have a great many people that go into specialist beds and general beds, but when they do, there's often a bit of a tussle about how long a young person should stay in, and obviously it's a case-by-case basis, but there's very much, you know, with the addendum to the access and waiting time standard, where they talk about the community team taking a lead in kind of guiding that process. That doesn't seem to be coming to fruition. It very much seems to be in the hands of the provider, saying, actually, we'll keep the young person until they're at their healthy weight range. Whereas we know from experience that getting a young person in the community not at their fully restored weight, we can actually do some really useful work in supporting, you know, working with the family. Whereas when they come out fully weight restored, they often kind of don't want to engage in treatment after that because they got what they wanted, i.e. their child is physically healthy. And I just feel there's a real kind of gap and need to sort of think more creatively about, it will save money, have shorter admissions, but also if the clinical team is ready and able, and I'm not saying we are because we need more resources, but when we are, I think doing that work proactively and getting the young person into community, back into school, back into kind of the world is much more beneficial at every level. And I just think it's a really big problem at the moment, that there's this almost like this, it does feel like a tug of war sometimes. I don't know, I wondered if you've got any comments on that and any kind of guidance.
No, I agree. I absolutely agree with you. The example that I would give you would be the craft model from North West London. So the North West London craft model very much tries to address this, and one way they've addressed it is through the community care coordinator remains the care coordinator throughout the admission. So it's the community care coordinator who's making the decisions, and that is all, and it's all based on the outcomes model. What is it that the aim of the admission is trying to achieve? Because I absolutely agree with you. An inpatient unit shouldn't always be trying to bring a young person back to 100% health, because we don't want to be looking at a young person's presentation in an instant in time. We want to be looking at that young person's presentation over the whole of their lifespan. And I think if we hold that into consideration, then we might be able to focus the inpatient units, the inpatient stays on where it's really needed and where we get the best value for resource.
Thank you so much, Guy. There are some really important points in the chat as well about taking a much more intentional trauma-informed approach to understanding the presentation of what lies beneath the needs of both children and young adults experiencing this type of need. And also Kevin from Kent has highlighted the relevance of the recent qualitative analysis of children and young people and really understanding the importance of the investment in youth engagement earlier on down the train, but also in these contexts that we've just described around acute settings and inpatient care. So Guy, there just isn't time to do justice to all the many points that have been raised, but we have had a fairly good shot at it. I'd like to really thank you for the time that you've spent with us today. I can tell it's been valued highly by the whole range of partnership leaders who attended this event across the South East. Thank you. I understand that you're offering to be available to colleagues for specific follow-up questions. We'll be sharing the slides, won't we? And also the good practice examples that you've highlighted to inform both commissioning and partnership coalescence around these children and young people and younger adults who really do matter in terms of our prioritisation. On behalf of everybody here, thank you so much for all that you have given and for speaking truth to some issues that are really quite difficult for us to unpick as systems leaders together. Thank you.
Thank you very much.
You'll notice on the right there's a little link so you can evaluate how you found this time together and the things that you'd like to be talking about in our future programme. We turn our attention in the next sessions to looking at the potential to expand the voluntary sector infrastructure. John will be joining us in some of that. We'll be looking at the 0 to 25 agenda. We're turning to homicide and serious violence in our next session like this, together in combination with the police and safeguarding nursing colleagues and our homicide leads across the region. So do please keep checking those links. It's been really wonderful to spend time with you today, and please do continue to send us your thoughts and your comments. Wishing you well as you continue to grapple with the complexity we're facing, and we'll send this information to you as soon as possible. Take care, everybody. Thank you very much.